Hi, good evening, and welcome to another True Women's Health Facebook Live. I am Dr. Celia Egan. I am the internal medicine side of our practice, and my specialty, which I've been practicing for about 10 years now, is the field of obesity medicine, which basically means I help patients lose weight with nutritional changes, exercise changes, lifestyle changes. And one big area that we're going to talk about tonight that is included is anything to do with the weight loss drugs that are out there. So for all the ladies that are listening tonight, and a couple gentlemen too, I hope you're there to help kind of learn and support the women in your life. This is meant to be interactive. This is a time now for you to ask any and all questions about any of the weight loss medications or anything about weight loss in general. We're hoping to keep, a lot of the questions focused on some of the newer medications because we know that patients have a lot of questions and there's a lot of information out there. So we're really looking forward to diving in deep to talk about kind of how these medicines work and, if you were a candidate for using these medications. So I have a couple of goals tonight. So let's just run through these goals. One, I hope to convince you that obesity is a disease, right? It's not a choice. It's not you sort of sitting there every day choosing to eat more food. Obesity is a disease that sort of works at your brain and is intertwined with a lot of our different organs, the fat cells themselves, our liver, our GI tract, our muscles, even the overlay of our gynecological organs like our ovaries are all involved. So remember, one, obesity is a disease. Two, anti-obesity medications really are a good choice for the right patient. I feel like what's plastered all over the internet these days is a lot of just back and forth about the use of these medications. And there's such wide swings of opinions, right? There's people who are like, we should put these medicines in the water, to there's people that, say that they're harming everyone and absolutely no one should take them. Of course, the truth is probably somewhere in the middle, and we really hope that the right patients can get on the right medications, but it's definitely a choice. All right, guys, so those are some of our goals for today. So let's move into thinking about obesity as a disease. So the first sort of slide that we're going to pop up here is looking a little bit more closely at the brain. So you do not have to memorize or think or remember any of these details, but all these beautiful blue, pink, and purple circles are parts of your brain, parts of the part of your brain called the hypothalamus. I think of our hypothalamus as the most primitive part about us, and it's truly deciding a lot of the basic things that we need to do to survive. So what do we need to survive, right? We need our temperature to stay in check. We need to have enough energy to be able to move our body and have all of our other cells function, like our brain cells and heart cells. And it drives our sort of sex drive and reproductive sort of thoughts and cycles. So there's a lot of important things that come out of our hypothalamus. One thing in general that you can probably relate to is our desire to be hungry and our desire to sort of move our bodies. And that's where a lot of this lives. As you can see, there's a lot of different arrows moving back and forth to the pink and blue parts of our brain that are deciding, what are we going to do with these fat cells? Are we growing or are we shrinking? Remember, every second your brain is sort of computing whether or not it thinks that that is a good idea. Of course, the parts that are not here are feedback from other organs. So the other organs we're thinking about that are sort of overlaying on top of this are our liver, our gynecological organs, particularly estrogen, which is the signal to the body, whether or not our body's ovulating or pregnant or breastfeeding. On top of that is our muscle cells. The fat cells themselves secrete hormones, one particular called leptin, that helps drive up and down hunger. What you can see here, in addition, are some green boxes. And those boxes are some of the older anti-obesity medications. So one that is a fan favorite that I've been using for over 10 years is a drug called phentermine. That is used in combination with another drug called topiramate, which the brand name for that combo pill is called Qsymia, which some of these words may be familiar with some of our patients if we've talked about it. So phentermine was the good part of the bad drug fen-phen from the 1990s. So fen-phen was from the 1990s. Everyone was super excited about it because people were losing a ton of weight. but another piece of that medication caused him heart problems. So that product was pulled from the market for safety concerns. But we've been using phentermine on label. The FDA approves it for weight loss for over, 10, 15 years now. And it remains a mainstay in obesity medicine treatment. And believe it or not, there are some patients who do really well on phentermine or Qsymia and or Topamax. And, it's really exciting for those patients. Of course, the percentage of those patients isn't as high as some of the newer drugs that we're going to talk about, but is definitely a piece that's there. One thing I sort of want to break this up into, again, is when I'm thinking about obesity medicine treatment for patients, I sort of break it up into three separate chunks. One is actual adipose tissue loss or fat cell tissue loss. So we're hoping to sort of relieve that pressure from the adipose tissue or fat cells. We hope to get that mass down, right? Those fat cells can push on our organs and on our joints, particularly causing a lot of disease. And that's when we're really using the marker of your BMI or your weight itself or your maybe orthopedic symptoms as a marker of how successful we are. The second chunk of patients that I think of when I'm thinking about treatment is anyone struggling with some sort of energy misbalance. So these are patients who maybe they have extra weight, but maybe they don't. And maybe one of their problems is they have extra blood sugar in their blood and that their liver and muscles are not responding the right way to the signaling coming from their GI tract about any sugars that they've ingested. Maybe, for instance, they have something called fatty liver disease, which is where we have fat buildup in our liver because, again, our liver's not processing that energy appropriately. So that would be a reason alone why I would start a anti-obesity medication. Now, a lot of the times, extra fat cells and energy processing run hand in hand, right? We see a ton of people who have diabetes and obesity at the same time, but they don't always have to. Meaning we do see some people who have something maybe like fatty liver disease, but maybe their BMI is only like 23 or 24. I definitely have some of those patients, right? And so that alone would be another reason why we'd pull the trigger on an anti-obesity medication. The third and last reason why I would start treatment is if people were really struggling with food cravings. So our food cravings can be something sort of quiet where, all of a sudden we can't stop thinking about that piece of chocolate. Maybe something that's periodic, right? A lot of women talk about the time during their menstrual cycle of having the worst craving. It's like, holy cow, get me some ice cream. But there's some people who really struggle day in and day out with really bad sugar and or food cravings. And that alone may be a trigger to start an anti-obesity medication. Again, a lot of these things run hand in hand. So if you're someone who's really struggling with a lot of cravings and sort of giving into those cravings and sort of intaking a lot of sugar or extra processed foods, the odds are that you'll probably struggle with extra weight, but that doesn't always necessarily have to be the case. And cravings are really uncomfortable. I sort of liken them a lot to delusions. So when we're thinking about the psychiatric world where, a delusion is a thought that isn't sort of accurate. And so the most extreme example is maybe someone would think that they're being harmed in some way that actually isn't true. A craving is the same way. Your brain thinks that it's not going to survive unless it has that chocolate chip cookie. We both know that that's not true, but that's not the signaling that's coming from your brain. And your brain is making it very uncomfortable to turn down sort of that highly processed food. And then we find that the more food, have that highly processed food that we eat, the harder it is to turn down. So there's drugs like topiramate in particular that can be really helpful at turning down some of those cravings. And that's that purple box getting at the GABA receptor at that part of the brain called the nuclear accumbens, which is super important. One of the older drugs that we use that for cravings in particular is something called Contrave, which has been on the market for a little over 5 to 7 years now. It's a combination pill again of two generic drugs. One is bupropion, which we've used for depression, pulling back on nicotine products, and another drug called naltrexone, which we use, which is actually an opioid blocker. And a lot of people will hear that drug being used in regards to counteracting opioid overdoses in the form of Narcan. But believe it or not, we use small doses of naltrexone with the bupropion, and that can be really helpful at curbing sort of cravings and particular emotional eating, right? So emotional eating is that feeling where, we are sort of overwhelmed with, maybe happiness, boredom, sadness, and that progresses us to sort of leaning on food as sort of a coping mechanism. And again, all that stuff sort of happens at the brain. Okay, so now we're going to move on to next, unless anyone has any questions about some of the older medications that are available, to sort of the medications that are the topic all over the internet. So we're going to move to the next slide and sort of show the importance of these medications. So what the hey are we talking about? We are going to talk about the class of medications called the GLP-1 receptor agonists. They have a lot of other names. They've been given the name Anush, which is sort of cute. But that's, on the street, that's kind of how everyone recognizes it. Now, these are the drugs: Ozempic, Wegovy, semaglutide, Mounjaro, the newer drug that's been FDA approved called Zepbound. Yes, these are all the drugs that we're talking about. How do these drugs work? These drugs work because they basically are mimicking a natural hormone that you have that leaves your GI tract. So follow along with me. When we eat, particularly protein and fat, our GI tract very elegantly secretes some hormones. We'll call it glucose-like peptide 1. That's why it's called GLP-1, in response to eating that food. And these hormones go to all these different organs and do the thing that you would expect it to do if your body was getting food. So as you can see, it goes to the brain, and it's like, brain, you don't need to think about food. So decrease the amount of food that you're eating. Don't think about cravings. Sort of function a little bit better because we have food here, so we're doing well. It goes to our liver and decreases the amount of sugar and fat that our liver makes, which is awesome. So we're seeing less fatty liver disease and less diabetes. And that's most likely the reason why the liver is most likely the target for why it's being used for diabetes in addition to weight loss. It goes to our muscles and assists the muscles about moving glucose from the blood into the muscles so the muscle cell itself can utilize that glucose. And what makes that so special is that our muscles actually consume about 80% of the glucose or the blood sugar that's there circulating around. And a lot of the times when that function stops working, the mechanism when there's different hormones that allow that blood glucose into that muscle cell, we see that blood glucose ends up staying in the blood and just causing a bunch of problems. So we're really trying to optimize the way that our muscles are sort of utilizing energy or utilizing that blood sugar. Another exciting area that these drugs are working is at the heart. And I think that this is probably the most exciting area because, of course, we want people to lose weight. Of course, we want their kidneys and liver to be functioning well. Of course, we don't want them to have cravings, but we get super excited for some of the data that we've seen of how well the heart responds to these medications. And what are we talking about? We're talking about what we call the contractility. So that means the way that the heart's able to squeeze and relax, and also the way that the blood vessels of the heart are sort of basically keeping the heart safe from those, blockages, or getting the wall super sticky, as we would talk about it, and moving cholesterol particles into the blood vessel walls, which down the line is leading to heart attacks and strokes. So that's pretty exciting if we're looking at all those different things. Okay, let's move to the next slide. And we're going to review really quickly the drugs that are sort of on the market and what we've seen in some of the studies. So about 3 or 4 years ago, the drug Saxenda was the first one on the market under the liraglutide is the generic name. The brand name is Saxenda. This was a GLP-1 that was used every day. And it was really exciting because we saw for the first time over about 5% body weight loss, which was pretty consistent across the board. And that was pretty new in comparison to Qsymia, which the averages were about 7 to 8% in a longer period of time. Then over time, over the next couple of weeks, semaglutide was put on the market, and that's under the brand names Ozempic or Wegovy. And remember, the active ingredient in both those drugs is the same. And I think that can be really confusing for patients because patients will say that they want one over the other, but truly their active ingredient is the same. And a lot of the times we're making choices about which medication to use. Sometimes we deal with coverage issues and insurance issues, and that's why we'll make that choice. But remember, you should know that they are the same active ingredient, and we'll try our best if this is something that you'd want to use to try to find the right one that would fit within your insurance and financial plan. All right, so here we are looking at semaglutide, which was so excited about semaglutide, and we will look at some graphs because I think visually it's much more exciting. They saw 16% body weight loss over a year or so, which was really great. And then about, last year at the Obesity Medicine Conference, they presented the data on tirzepatide, which is just about three or 4 weeks ago, was FDA approved under the brand name Zepbound. And what they saw was almost close to 21% body weight loss in comparison to placebo of 3% over 5 years. And I think just to give some comparison, so again, I've been working in the obesity medicine space for about 10 years now. And some of the targets or goals that we've been looking at, we were really excited when people could lose and maintain 5% weight loss. And if they got 10, we were super excited. So just let's talk about what that looks like. So if you're a patient who maybe is 200 pounds and you're looking to lose weight, 5% body weight loss is 10 pounds. And it can feel, this day and age, that doesn't feel like very much. So you can imagine how exciting it is to be a doctor in my space and see numbers like 21%. That's like 40 pounds. That is getting patients closer to what they would consider an ideal body weight. And for the first time, we're getting weight loss numbers with medications that are similar to bariatric surgery, which bariatric surgery is a good choice for some patients, but it's also great to have some of these other options available because obviously the right patient may or may not want bariatric surgery. All right, so we're going to move on to look at some charts. And again, we are so excited if there's any questions that are available because I think that that's always a great place to get started. So let's look at this in graph form. So this is looking at semaglutide. So on the left, what you can see is the top line is the placebo, meaning they're still giving patients injections, but they weren't an active ingredient. And the bottom line is semaglutide, which you can see the percentage weight loss was, above 16% over time frame. So that's really exciting. On the right, what you're looking at is the percentage of patients who lost from the left to the right, 5%, 10%, 15%, and 20%. And if you look all the way to the right in the semaglutide, that's that dark green bar, even though the average was only about 15, 16%, still about close to 40% of the patients still lost over 20% of their body weight. And that's on semaglutide, which is really exciting. All right, let's talk about the next box. I'm looking at tirzepatide. And the next slide. Okay, so again, I feel like visually this is really, really, it just speaks for itself of how exciting this is. So the top line and box is the placebo. So those are patients who are getting a medication, and we're going through all the same rigorous lifestyle intensive management as the patients who are getting the drug. And then the next bars down are the different doses of tirzepatide, 5, 10, and 15 milligrams. What you can see is even at the 5 and 10, which are considered the lower and medium doses, patients were losing a great deal of weight. It was almost like they had to not make the bar graph bigger. It was just so exciting. You can understand in our space how, we are really excited about seeing sort of numbers like this. And again, in the next sort of slide, what we're going to look at is similarly thinking about the percentage of patients that lost 5, 10, 15, 20, and 25% of their body mass. And these are at the different color bars. In blue are the different doses, the 5, 10, 15%. So if you look all the way to the left, one of the most exciting things, I think, is that even at the 5 to 10%, 85% of the people at least lost that. So that's how successful people were. And as you can see, even moving all the way to the far right, almost 32 to 36% of people lost over 25% of their body weight loss. And I would say that this bar graph, in my experience of using these medications at our office, which we do often for the right patients, that this is definitely what I can say that we see, and it's quite exciting. All right, and we're going to move on. So that is our last slide before we sort of can talk about questions. I have some questions that I hear all the time in our office. So the first question that I hear all the time when we get started are, am I a candidate? So who's generally a candidate? One, we talked a lot about using BMI as a marker, and that's kind of what is pretty standard within the Obesity Medical Association and the Obesity Society. So anyone who has a BMI above 30 or a BMI above 27 with a comorbidity such as high blood pressure, high blood sugars, high cholesterol levels, coronary artery disease, obstructive sleep apnea, osteoarthritis at knees, hips, back. Actually, there's some other ones that, I would say I also throw into addition. So I'm thinking of reflux, obesity caused reflux, pre-diabetes, insulin resistance, PCOS, gestational diabetes from prior issues with pregnancy. All those would signal to me that a patient was struggling with some energy processing problems and that we need to address some of those levels. Okay. A second question that all patients ask me, are these medications safe? Whew, that's such a big question because I feel like on the internet, we hear 1,000 different things. So one of the things when you have to think about using medication, no medication comes risk-free. All medications have side effects. That's what they are. But there's also a risk of not taking care of these problems, particularly if you're struggling with energy misbalance, meaning high sugars, prediabetes, fatty liver disease, high cholesterol, high blood pressure. That is a risk of itself of not being treated. So whether or not one of these medications is something you want to choose, we got to do something there to help you sort of get those things in line. So just sort of a reminder. What are some of the side effects we see, particularly with the GLP-1 receptor agonists? So because these drugs mimic things that are happening in our GI tract, a lot of it's GI tract stuff. So what do I see? Nausea is a common one, although I'll say with tirzepatide, the addition of a second molecule that makes up tirzepatide and all the other successful weight loss, we see less nausea. Constipation is another major one. Sometimes people get the opposite effect, maybe looser bowel movements and reflux. I will say if you're not eating the right things, and that's what we're here to help guide you as a obesity medicine office, what those right things are, these symptoms can get worse. I remember I was reading some articles about some celebrities and they were saying, they were not really making any sort of lifestyle changes in addition and really struggling with a lot of the GI side effects. I would say in our office, we see less of that, but we really do pride ourselves in trying our best at getting people prepped to eat the right things. So if you're going to eat something super heavy, so heavies meaning, fast food, maybe fast food and some alcohol, fast food and a shake, right? A really, really heavy meal where you're mixing a lot of sugar, a lot of fat, a lot of protein together, you probably will feel nauseous. But if you're able to sort of keep it easy, again, you're going to have some of those things. For the most part, the nausea tends to stay at bay. So GI tract stuff is one thing that we take very seriously and is a real consideration. The second grouping of side effects that we see are people just don't eat enough. So think about that brain and how that medicine goes to the brain. I can't tell you how many people come back to me in the office for follow-up and will say, I stopped eating, right? You have no desire to eat. And we really do have to work on getting you the right nutrition and finding you the right dose. This is where I think the dosing takes some finesse. We really don't want to turn that signal off completely. We still want to make sure you're getting in healthy amount of protein and fiber and healthy fats to sort of support your body and nutrition. So it is not our goal to get you to not eat for days and days and days that you sometimes can see on the internet. It is all about finding sort of that right dose and having someone there to support you. A third section that can happen with the weight loss drugs is hair loss. So hair loss is true with any type of weight loss plan. So whether it's bariatric surgery, meal replacements, major dietary changes, calorie restrictive diets, just like the weight loss drugs, hair loss can be something that happens when people are losing upwards of 15 to 20% of their body weight. I will say I've seen some bariatric patients lose sort of a ton of hair, but I will have patients comment that they feel like they have less of a hair like in their ponytail, but overall, I haven't seen anyone lose a substantial amount that, they've been balding. Of course, we're working hard on sort of minimizing that as much as possible and trying to get the right patients on sort of the vitamins and ensuring that they're eating a good amount of protein and healthy fats to sort of keep that in line. There's a lot of hubbub about thyroid cancer. So on the box, there's a black box warning that the rodents in the animal studies developed something called medullary thyroid cancer. I will say that that is not something that has been shown in the studies. If you look back at those slides, tirzepatide itself is now in year 7 or 8 of being studied. We've been using these medicines for almost 15 years in patients with diabetes. I personally do not worry at all about thyroid cancer. If you're someone who's had a personal history of medullary thyroid cancer, we would say that you would not be a candidate. But even if you've had thyroid cancer of a different type, we still have some patients that use these medications and are doing well and have not gotten cancer. So I do not worry about thyroid cancer, but it is something that we think about. But speaking of your thyroid, if you're on thyroid replacement, we'd want, again, someone who knew what they were doing, and we'd want to check those levels to make sure that we didn't need to adjust your thyroid replacement as you're losing weight. So it's still always something that we'd want to think about. All right, some other questions that I have. So, can you discuss cost coverage with Priority Health? Cost is a big issue. Carolyn, thank you so much for that question. And I will say my heart aches for all these people, and we continue to work on the back end with some of the bigger groups across the country to try to make these drugs more affordable for people. So particularly the Obesity Action Coalition sort of is working on some legislation to sort of get this pushed through so that insurance companies do not have the ability to sort of not provide coverage for patients. So there are some insurance plans that are not picking up these medications. In addition, there's some plans that you have to fail other medications first, which is a little bit of where Priority Health is at currently as of right now. I will say that the data that keeps coming in about these drugs, it's getting to the point, as I've said, particularly the cardiac data, it's getting to the point that I can only believe that at some point these drugs will be covered, because it's just going to get too hard not to cover them because the benefit is seemingly just growing and growing, particularly when we're talking about, adding sort of years and years onto patients' lives. So I definitely can say that I feel you about the cost and coverage issue. We know all the cash ways of getting these drugs covered for patients. And it's a great discussion to have with us in the office if that's something that, you're interested in and that your insurance plan doesn't cover them. So thank you for the question. But I can realize exactly how frustrating it is. All right. Question from Lisa. If there's some of these have been out and used for that long, why isn't there a generic option? So some of it has to do with the injectables and how the mechanism by which they're delivered. So although they're not a pill, they are sort of within this, auto pen-like capacity that sort of limits the ability to make them mass produced. There's still this whole class of medications has been out. So for instance, there's a drug called Trulicity, which is used for diabetes. They just keep perfecting it. So at the level of weight loss level of tirzepatide, that's the one that's still under patent and still is not generic as of yet. We still have a couple more years before the more successful ones will have a generic option. A big topic of conversation is something about using compounding medications. So there's a lot of non-medical facilities such as many spas and some doctors' offices that are using compounding pharmacies. So compounding pharmacies are pharmacies that are trying to make drugs that are not by the major company. And as of yet, the Obesity Society and the Obesity Medical Association and the Bariatric Society has really warned against sort of using compounding medications, which I think is very complicated for patients. I think one of the concerns is that from a compounding medication, which is not regulated by the FDA, we're just not sure what those medications are. And we prefer patients to use the FDA sort of the FDA indicated medications, even if we're using an off-label medication. So a lot of the times we will use Ozempic for weight loss if from a coverage capacity that makes the most sense. That's why we've chosen in our office not to use compounding medications, because we do sort of prioritize safety first for all patients. Although we know that's been a tough choice because it seemingly feels as though the compounding drugs seem to be a cheaper option. But as of right now, that is not something that we're looking into. And we feel pretty supported by sort of the messaging coming from the major societies that are sort of backing this information. All right, we've had a ton of other questions coming in. Okay, how do these drugs work with antidepressants or statins? Great question. For the most part, you can use these drugs with those medications. So antidepressants, as of now, are not something that's contraindicated. Some of the other drugs like Contrave are used for antidepressants, and so we would just want to make sure that that's not something that would overlay on top. You can also use these medications with statins. I will say, though, that I've seen people's cholesterol levels just fall completely down. And a lot of the times we've been able to take away their statins or at least reduce the dose safely because their cholesterol levels are just so much better. So yes, you can use these drugs with both those types of medications. And the next question, do these medications need to be used for life? If so, what does maintenance look like? Great question. Thank you so much for asking. So these are not short-term medications. What am I talking about? So a lot of the weight loss plans, so again, if we're thinking about obesity as a disease, a lot of the weight loss plans from 5-6 years ago, right? And even now, some doctors' mantra is, if you just lose the weight over 6 weeks, therefore you're all set. Nope, that's not how this works, right? What we're doing is we're trying to change the different messaging that's coming into the brain, if not changing the brain itself. So this is not a short-term plan. We're not thinking about weeks to months. This is months to years at least. That being said, right, what would happen if every person uses these medications, loses weight and stops them? Will every person regain the weight? The answer is I don't know, right? A lot of the times, women in particular have these clinical pathways that happen that seem to snowball. So what am I talking about? A great story that I hear very frequently is it'll be a woman in her 40s. She's entering to perimenopause. Maybe she'll have some sort of orthopedic injury, like an ankle injury, or she was running and had some sort of knee injury, can't work out for 6 weeks, high stress, has teenagers, has elderly parents, and it's this snowball effect where all of a sudden she's gained 30 or 40 pounds. All right, now she's in my office, right? And we talk about using some of these medications. I honestly can't say I don't know that if over the course of 2 or 3 years, right, we get her to lose weight, we get her back on her exercise program, we get her sort of thinking about mindful eating and sort of reflecting on her cravings, we get her sort of managing stress and thinking about it a different way. We're changing some of that processing that's at the liver. We're changing some of the processing that's at our brain. We've kind of optimized our muscles as much as possible. We've gotten our hormones under better control, all these amazing things that we do at True Women's Health, right? Can I 100% say that that patient's going to come off that medicine and they're going to regain every pound back? I can't. I will tell you, if you use this medication short term, so some of the stories that are out there, right, are, I had a binge eating disorder. I used this for 6 months. My binge eating got better, but yet I didn't do anything else for my binge eating. I didn't take any other mood medications. I didn't sort of seek out therapy or anything else to sort of use a better set of coping skills. And I stopped the medication and I went back to binging. Yes, you will regain all the weight again. This is not the only thing that is done. It's one of the things, and it does make the journey easier. Even that being said, so we've done this in some of the studies. If you look at the semaglutide studies, what they showed was, they got people on semaglutide, they got them to lose their weight, and then they took them off, kind of cold turkey, right? And they let them do their thing, not really hand-holding, not doing anything else. And what they saw was they did regain the weight back, but they did not get back to where they were. And they still were 50% down from where they were before. So the answer to this question is we just don't know. This is such a new space that I can't say with certainty that you will regain every pound back. I will say, though, it is not a short-term plan, and it should be something that you're looking at for months to years, not weeks to months. Okay, hopefully that answered that question. Next question. Can you discuss the importance of exercise, specifically lifting, to minimize muscle loss? Great question. And I think this is really important because any patient who's losing weight, whether it's a calorie restrictive plan, bariatric surgery or any of these weight loss medications, it's really important to sort of prep your body into reminding yourself that your muscles have to stay. So exercise, particularly weightlifting, is really important because it's sending that signaling to your muscles that they have to sort of stay and not go away. So that's really important. And any time that you can add in truly any weightlifting plan, so whether it's, isometric training, which is like yoga, Pilates, or resistance training, or even heavier weights, that's always a great idea. Great. Thank you for that question. All right. What happens if I've lost 22% on my Wegovy, still on Wegovy, but my hunger pains are back and I've actually gained 3 pounds back? What should I do next? I think that that's a great question. A lot of the times what can happen is we need to sort of reflect a little bit on mindful eating and then some of the nutritional changes that you've made. And it can be helpful to sort of go back to the beginning of sort of healthy eating and do a bit of a cleanse, sort of pulling out some of that stuff that sneaks in over the holidays. And that'd be the next best step. If you're feeling like you still want to lose weight, a lot of the times adding on additional medications can be helpful. And I know that feels frustrating to keep adding on medications, but even for a short term, some of those older drugs we can add on top of Wegovy to help kind of keep patients on track. And it can be a little bit more complicated than just doing one drug at a time. And a lot of the times the style within the obesity medicine world is to sort of have an additive effect, even for a short time, in addition to some of the GLP-1 receptor agonists. All right, next questions. Are there alternatives to Wegovy to help maintain weight loss once you've hit your goal? Once hit goal, are there any other options maybe in pill form? The answer is yes. All these drugs are sort of available, and a lot of it depends on sort of your history behind, how you got there, whether you're struggling with energy balance, whether you're struggling with cravings. And this would be a great question to talk to us about in the office. But the answer is yes, there are some other pill form options. All right, we're looking next at our next question. I've lost 65 pounds, but I still have another 60 to lose. Thank you. Oh, well, first of all, congratulations. Losing 65 pounds is no small feat. And, I'm sure that you've made a lot of changes in your life to sort of help get you there. I think that in addition to Wegovy, there could be some other options, such as changing to tirzepatide or adding on some of those other medications and adding on other nutritional exercise and mindfulness exercises that you can use to sort of help get you to the other 60 to lose. So again, congratulations. That's no easy feat. All right, we want to just make sure. Is it true that once you're off the injectable, you gain the weight back? Are these medicines a lifelong commitment? So again, it's hard to say whether or not it's a guarantee that you'll regain them back. So again, thinking about that one study where they did that, they got people to lose weight and then they pulled the medicine. Even then in the studies with people not sort of having minimal support, they did regain some weight back, which is true with bariatric surgery as well. A lot of times we'll see this dip down and then a slight bump up, but they still lost 50% than the placebo group, even after pulling the medication. That being said, for some people, this may be a lifelong commitment. I'll be honest, I have some patients that don't want to go off these medications. One, because it's calmed that food noise so much. It's made this journey just so much easier that it feels just easy to do, right? And that's okay. And I think that that's a great first step. Another question I get a lot is this the easy way out? I promise you, friends, it is not. Again, obesity is a disease, right? Just like if you were struggling with cancer, just like if you were struggling with an autoimmune disease, this is not your fault. It's a mismatch of a lot of the signaling that's happened throughout your body. And it is not the easy way out to have drugs to help support you on this, to try to get your body functioning better, to get to any health goals that you want to be at, or life goals, right? Functioning goals. A lot of us talk about seeing our grandkids, hanging out with our grandkids, being able to do all those amazing things. And those are the things that we're hoping, that those are the reasons why we're using these medications and trying to get people sort of back in line. All right, another question. Will this be recorded? Yes, this will be on YouTube. And as always, people know how to reach us at truewomenshealth.com. And so that will be available. I just want to say one more question that I hear a lot from patients, which is particularly some of my younger patients, which is, if I'm using these medications, am I like not being true to my body image? And the answer is no, right? And, I think some of this mantra of, that somehow if we're struggling with extra weight, but we want to lose weight, but we're really not sure, but we're not really sure, but we love ourselves and we're not trying to find sort of the balance in that space, it can be awesome to think about maybe a different goal. Whatever that number is on the scale, whatever size clothes you are, that doesn't really matter. And I honestly don't truly care about that. What I care about is what I said. I want people functioning better, having less sort of fat cells on their body so they can move their body whatever way they'd like. A lot of us love being active. So whether it's being able to do tons of yoga or tons of running or tons of hiking, right? Anything that we can do to make our bodies functional. 2, your energy processing has to be going well. Why? Because that's what leads to chronic disease. Chronic disease I'm talking about are vascular disease, cancers, dementia, all that stuff that happens in your 80s and 90s, right? So if you're having an energy balance problem, then you should use all resources, whether or not that's medications, nutritional changes, exercise changes, lifestyle changes, but including medicines to get there. That is being more true to your body than not. And you can still love all the imperfections of your body, but still want to get that energy balance in the right way. And lastly, if you're struggling with cravings and you can't do the things you need to do, right? Like get to school, get to class, function throughout your day without those cookies sort of calling you from the break room, we got to do something about that. You ain't got time for that. We have to do something more to sort of get you back in line. So you are still being true to yourself, even if you're using some of these medications. Okay. So we are moving next to our, I think there's one more question. Let's see. I used this medication and I got really sick. And then when I tried to restart, I had the same results. So would a different drug have similar results? So Saxenda was the first round of these medicines. I will say, as time has progressed, particularly with tirzepatide, the side effect profiles have gotten intensely better. And I do mean significantly better. I can't promise that tirzepatide won't be something that doesn't cause nausea, but I will say that I've had patients who have had success moving from a drug like Saxenda to tirzepatide without as many GI side effects, which has been very exciting. So I would not wipe all these drugs completely off the map for you, and I would think about sort of what that looks like. Okay, if there are not any other questions, we're going to move to our 5 take-home tips. 1, obesity disease. I hope I convinced you that today, obesity is a disease. It is not your fault, right? And there's a lot of different things we can do to get this disease in line for you if that's something you're struggling with. 2, it is not your fault. Oh my gosh, friends, if anything you take away from this, if you're holding on to extra weight, it is not your fault and you deserve to have some sort of solutions. And maybe it's medicines, maybe it's not, but that's what we love talking with our patients about, are all the different ways that we can sort of get whatever health goals they have online and sort of bring down any barriers that they need to, because it is definitely not your fault. Number 3, anti-obesity medications are safe and effective for the right person. I really hope that if you're someone who's struggling with some of these topics we talked about, I convinced you enough to at least have that conversation with a provider who has some background in obesity medicine and at least has sort of run through the risk and benefits for you, if that makes sense. All right, number 4, lifestyle still matters. So we sort of touched on this briefly. So this is not the only thing that we need to do. We still really want patients to focus on healthy eating, getting good sleep, getting good exercise, all those seeds that we talk so much about in our office. So those things still really matter. And as you know, your providers will definitely try to keep you on track in that department as well. All right, number 5. The first step, safety. So we touched on this a little bit. We really want to make sure the right patients are on the right medications. And please work with a doctor who knows kind of a little bit about these medications, including, not every person will be able to find an obesity medicine doctor, but at least someone who has some experience in this sort of space. And, as always, we would prefer people to use the FDA approved versions of these medications just because we can verify what they are. So always think about your safety first. All right, now we have 5 tips to talk to your primary care doctor about, because we know that not everyone can come see us. Although I would say we're expanding to many states: Michigan, Ohio, Illinois, Wisconsin, Florida is our newer one that we're really excited about. So if you cannot see us, these are the tips to talk to your doctor about. All right, number 1, am I a candidate for obesity medicine? Remember, you are a candidate if your BMI is above 30, or your BMI is 27 with some other energy balance problem, high sugars, high cholesterol, high blood pressure, obstructive sleep apnea or osteoarthritis, and maybe some other things. So yes, you would be a candidate for sure if you fall into these categories. All right, question number 2. What is your experience using anti-obesity medications? Similarly, when we talk about the use of hormone replacement therapy, if you're working with a doctor that has a hard no stance on anti-obesity medication, you should find a different doctor. They at least should have some experience, and getting the right person on these right medications is imperative. And if they have a hard no for all these drugs, please find a different doctor to talk to. All right, number 3. What are my supportive resources? Again, lifestyle matters, and maybe you still want to see a dietitian to make sure that you understand what maybe heavy foods are. You want to make sure you understand what your protein sources are. Maybe maybe the resource you need is someone who works with like emotional eating and finding the right therapist. So, talking with your primary care doctor about what are the resources that they have available to kind of help support you on this journey, so that maybe if and when you wanted to get off these medications, you're totally supported and ready to go to sort of make those next steps with healthy eating and keeping your body intact. All right, number 4. What is my phase of ovarian function? Oh, Dr. B would love this. I know she's not here tonight, but I know she'd love it. All right, let's think about this a little bit. We are talking about all that signaling that's coming back from your body to your brain. One of those most important parts of our body are our ovaries and our gynecological system. They're there to tell the rest of our body what's happening with I always call it our side project. Our side project's having babies, right? As we move from reproductive phase into perimenopause and menopause, those sex hormones go a bit bonkers. And what that does is it changes all that energy processing at our muscles, our liver, and at our brain as well. And so you need to know what your phase of ovarian function is, because that may change the way that we're going to make anti-obesity medication adjustments. I will say what's really interesting is the body alone, without any changes to calorie intake, decides to put on extra adipose tissue during 3 major times in your life. 1 is puberty, 2 is pregnancy, 3 is menopause. Yeah, congratulations, right? So if you're added into that perimenopause, early menopause time, this just may be this time in your life that, thank goodness, we have some of these good drugs that we can add on, get the adipose tissue down, get you where you need to be, even for a short time, and sort of see what this next chapter looks like. All right, number 5. What is my end goal? So we talk all the time about our picture of self and what we want patients to visualize where they want to be. And again, it doesn't necessarily have to be a weight or a size. We don't care about that as much. We really want people to think about function or preventing chronic disease. And so it can be really helpful to have some sort of end goal. And that alone then can be helpful to help us decide what we're going to do with medications, either start or stopping them. And again, even just curbing your cravings for sugar or, highly processed foods can still be an end goal and something that we can help you achieve. All right, that was a ton of information. I really hope that patients got a lot out of that. As always, you can reach us at truewomenshealth.com if you want to talk more about these topics. We're always excited to see new patients, even if you just want to do our weight journey, which is just talking with me about how you can lose weight. That is a great topic. If you're in any of the states that aren't in Michigan, we can definitely help you, even if it's via telemedicine. So we're very excited. Thanks all and have a great night.